And we all know that most of the people above 60 and 70, they come with some set of problems. And most common problems when they come to urology OPD is because of the urinary symptoms. So the most common urinary tract symptoms when they come to the OPD is either they will have frequency, urgency, or nocturia. Both the males and females will have the same set of problems. So in males, the causative factors can be multifactorial because of the obstruction of the prostate, or because of the urinary tract infection, or because of the long-term diabetes, or any other UTI-related symptoms. They can have this frequency, urgency, and nocturia. And the lower urinary tract symptoms consist of multiple other symptoms also. Even a stone which is coming from the kidney inside the urinary passage also can cause this frequency, urgency, and nocturia. Even any bladder tumor or any other specific non-specific symptoms also can cause similar type of problems. So, in particularly people who are elderly, say 65 or 75, when they come to OPD, they complain of either they have decreased stream urine, or when they go to the restroom, they feel that they're passing too much. They're passing urine a long time as compared to the person who is standing next to them. Some people will say that I'm straining to pass urine, even the strain also, the flow is not improving. Some people will say they have dystency, that when they start the urine, they'll have some kind of lag before the initiation of urine. And on stop and passing of urine also is part of the urinary tract symptoms. So nocturia is considered as passing more than 2 times in the night. So whenever a person goes to bed, say if he goes to bed at 10 o'clock, and if he wakes up by 6 o'clock in the morning, if the person is passing more than 2 times in a night, it is considered as nocturia, and usually causes disturbed sleep also. Because of this, there will be a problem in the quality of life. They are not able to sleep properly. They may have the whole day will be disturbed. Most of them it causes multifactorial. Either it can be because of the prostate or other related symptoms, or because of the cardiac related symptoms. Even cardiac related symptoms also can cause increased urine production in the night. So all this can cause nocturia. Some people, rarely they come to the hospital with urinary retention. So sometimes they have a blockage of urine. So they come to casualty. When they come to casualty, or when there are no, they have very painful lower abdomen. When they examine, they'll have a distended bladder. So it can be of 2 types. It can be acute retention. That means the patient is having symptoms very short while, say 2 months or 3 months, that is having this urinary problem, and suddenly one day, because of the infection or something, he will suddenly come to the OPD with not able to pass urine. So they have acute pain. And the other thing is chronic retention. So these chronic retention patients, they have these urinary symptoms for a long time, say years together. And even after passing urine, there will be some amount of urine which is left behind. So slowly this accumulation of urine will go to extent that the bladder itself will have a capacity of more than 1 liter. And these patients, when they pass urine, a lot of amount of urine can be staying back, but they don't have any pain. So that's how we differentiate a patient with acute retention and chronic retention. Whenever you put a catheter in acute retention patient, they will have some 500 to 600 number of urine coming out. Whereas in chronic retention people, when they put a catheter, they'll come 1 liter or 1.4 liters of urine will be coming out. So most of the times the pain is the main causative thing, and the other things we'll see what is the cause for this chronic retention. So especially in the females, I think Madam is going to talk about this. So they present with urinary incontinence. So urinary incontinence is a very vast subject. Basically, it has a lot of interpreting things. What you need to know is there are major 3 types of incontinence. Incontinence, urine leak. One is urge incontinence. You have a strong urge to pass urine, but before going to restroom, the urine is leaking. So it is called as urge incontinence. One is stress incontinence. Stress incontinence is what we come across for most of the patients who have undergone robotic procedure. What you come across, the incontinence is called as stress incontinence. So whenever you are getting up or whenever you are trying to sit in the chair or getting from a chair, when you laugh or when you sneeze, so there will be increased abdominal pressure which will cause an amount of urine to leak. So that is called as stress urinary incontinence. And in some patients they have both mixed incontinence. Both stress urinary incontinence is there, urge incontinence is there. So in these type of patients, the main thing to know is whether they are having any UTI or not, urinary tract infection or not. and any pelvic related or any nerve related problems is there or neurogenic bladder. So I think Madam is going to talk about this. And some patients will present with hematuria, blood in the urine. So sometimes when you collect the urine sample, when you take the urine sample and see, you can see the urine itself is grossly red in color. Sometimes urine may not be red in color, but there can be a microscopic hematuria. Only when you see under microscope, you will see some amount of red blood cells inside the urine. So the usual red blood cells which should be present inside urine should be around 2 to 3. Imagine if the red blood cells are more than 5. Whenever they examine the microscope, there will be a square-shaped structure. They will see how amount of RBCs are there in the square amount of structure. So if the amount of RBCs are more than 5 cells, it is called as microscopic hematuria. Whereas when you grossly see with your naked eye itself, the urine is red in color, it is called as macrohematuria. Most of the patients in elderly, the hematuria can be because of urinary tract infection. That is the most common cause, UTI, infection, urine infection all over the blood hematuria is the most common. The other possibilities can be stone. Stone, whenever it is coming from the kidney to urine passage, it can come to the ureter, which is a long tube. Whenever it touches this tube surface and comes out, it ruptures some area, which will cause some amount of bleeding in the urine. The third most common cause is malignancy. Any cancer in the bladder or any cancer in the kidney can cause this type of bleeding. So UTI, urinary tract infection, is the most common infection which we come across in the elderly people because of a lot of factors. One is diabetes. So elderly people are more prone to have diabetes. Increase in sugars causes increase in sugars levels in the body, which invariably the patient will pass some amount of glucose in the urine. So whenever patient is passing glucose in the urine, or bacteria which is there in the tract, or bacteria which is there in the skin surface, penile skin surface, or in the for females in the labia and everywhere, the glucose which is there in the urine will proliferate the bacteria, which will increase the bacteria, because the bacteria also need some amount of glucose to feed, glucose to multiplicate. So all this glucose which is coming from the body itself, it is happy to strive in that and it will increase and multiply and will cause the symptoms. So diabetic patients who are hospitalized for a long time, imagine a lot of antibiotics were given and these infections which are there in the body will get resistant to this antibiotics and then can cause UTI. Some patients who are on steroids, patients who are on chemotherapy drugs, all these things, steroid and chemotherapy drugs will cause decreased immunity in the body. So whenever there is a decreased immunity, bacteria will also proliferate. Even the small bacteria, which usually doesn't give us any problem, will start giving problem. So coming to the age-related enlargement of prostate. So most of your patients have undergone the robotic prostate surgery because of the urinary tract symptoms. So how you got to diagnose? By 2 ways. Most of the people will not diagnosed by 2 ways. Either some amount of bladder, prostate which is enlarged, because of that the symptoms are there. That's why you came to a urology OPD. While examining, we found to have that there is some urinary trouble, and apart from that, the PSA is elevated. So either by this thing, or you have undergone some Marshall checkup. You don't have any urinary troubles at all, but you have undergone some Marshall checkup in which you found to have an elevated PSA. So usually, most of our patients who got diagnosed with the CA prostate will come with the BPH symptoms only. BPH is nothing but all the men will have this prostate, which increases with age because of the testosterone hormone. So the location of the prostate is very important because through the prostate organ only the urine passage is going in the middle. So imagine there is an apple fruit. In between you see the seeds in here, you see the seeds. So the seeds is nothing but a urine passage, which is a hollow tube. So the prostate is enlarged. So the prostate is enlarged and causes compressing this urine tube which is going in between. 360-degree enlargement which is causing compression. So when it causes compression, flow will be decreased. The amount of urine which comes out will be little less, and the amount of urine which is staying back will be little high. This will cause nocturia. Night time when you are passing urine, you are not able to empty the urine completely. This can cause some amount of cystitis, bladder infection, because the urine is not emptying completely. And you have some amount of frequency and urgency because of all these symptoms. So, age-related enlargement of the prostate is the main thing which makes the patient to come to OPD. When we examine this patient, most of the patients will have a normal PSA, and when we examine through the motion passage, the prostate will be absolutely normal. Some patients, in the age-related enlargement of the prostate itself, they can have cancer which is there inside the some of, if you say apple, one part of the apple can have half of the cancer. How we diagnose is by putting a finger inside the motion passage and feel the prostate, whether it is soft like this or hard like a bone. So when you feel the prostate, you get to know whether there is any problem or there is no problem. So we correlate with the PSA levels and also by examining this thing and find out whether you require any staging or you require any MRI scan or not. So patients who doesn't have any cancer or PSA elevation or examining to the motion passage is absolutely normal. So we evaluate by doing this IPSS score to find out how symptomatic they are. Everybody will have this prostate enlargement, but most of the patients may have symptoms. Sometimes they have symptoms which are moderate level, which they are able to manage. Some patients will have lot of symptoms which they are having disturbance in daily activities. So this questionnaire will help us how significant their symptoms are. And if you see this questions, 7 questions are mainly to pertain how is the urinary stream and everything. The 8th question is all about how is the quality of life, how much disturbance it is happening. So with this questionnaire, we'll find out, they will give us scoring to it and to find out how severe the symptoms. Based on that, we'll get the treatment. So imagine patient is having a mild or moderate symptoms after filling this questionnaire. So we'll try to put these patients on some medications and see whether there is improvement or not. Patients who are having severe symptoms, they may not respond well with the medications, we may suggest a procedure for them. So, any patient with a prostate problem, we always examine the motion passage, that is digital rectal examination. DRE stands for digital rectal examination, an examination of our abdomen and everything. And what we examine in the digital rectal examination is what is the approximate size of the prostate, whether how is the consistency, whether it is soft or hard, how is the surface, whether it is smooth or any nodular. So all these things will help us to see whether the enlargement of the prostate is a cancer or it can be just a age-related enlargement will be to know. So apart from that, we always do all these tests, all these tests where we see any creatinine elevations there or not, PSA and urological to find out the symptoms. So the normal urine flow test, whenever you do, you would have seen the flow. So the normal flow should be a bell-shaped curve. Whenever there is any prostate enlargement, the curve will be very slopey curve. So the patient is able to pass urine, but it takes a long time to pass. Whereas this thing you see, there is a box-shaped curve where there is any narrowing in the urine passage. Stricture, the penile urethra, is there any narrowing in the urine tube? This side of uroflowmetry you see. So based on uroflow, we can know whether this patient is having which problem or whether if we give medications, can he have any improvement or even if the medications also sometimes they may not have improvement. So subjectively, objectively we have evidence that this patient is having the symptoms or not. So any patients with BPH, that is just enlargement of prostate, we'll see whether they are having. We can wait and watch because the symptoms are not there, but he's having a prostate size of 35 grams or 40 grams, but still he doesn't have symptoms, no need to give any medicines straight away. Some patients will have mild amount of symptoms, they will be getting up in the night 2 or 3 times, and they have a decreased urine speed, but with the medicines they may have this improvement and they don't have the symptoms like before. So those patients we manage with some medicines which was given in the night time only. So these medicines will have significant improvement in some patients, and usually patients who are not complaining or the symptoms are reduced, we just follow them up. Some patients will be having symptomatic relief for 3 to 4 years or 5 years, they won't feel any discomfort or anything. But after 6-7 years, they may feel that with the medicines themselves, they are not having any improvement or the symptoms are coming back. So those patients we opt for surgery. So most common drug what we give is the alpha blocker. Alpha blocker is nothing but a medication which will help to relax the prostatic area. So the prostatic area will be completely relaxed and they'll have a better urinary flow. So sometimes we may get drugged out 5-alpha reductase. So 5-alpha reductase is nothing but a drug which will shrink the prostate size. So 5-alpha reductase is a drug which will block the testosterone hormone. When the testosterone hormone is blocked, the amount of prostate tissue also will become reduced. So in 6 months' time, the size of the prostate can be reduced and they can have some symptomatic relief. So what in some patients who are having a bigger size prostate, say 30 grams or 40 grams of prostate, we use both alpha blocker and 5-alpha reductase, which is a combination drug which will relax the prostatic area and also decrease the size of the prostate. So despite this, the patient is not having any symptomatic relief, then the patient is subjected to any surgery. So the most common surgery what we do is a URP, where we put a camera inside the urine passage and see the prostate area and remove the prostate area with a small amount of current, where we remove the prostate tissue with the help of a loop. You can see a U-shaped loop here now. So with that loop, we'll cut the prostate and remove those chips from the urine passage. So that the block here, the block here will be relieved and there will be a cavity which is created and patients can pass urine in a better way. So like this. So this is laser enucleation, where the blue color thing is a laser, where we enucleate the prostatic lobes and create this much amount of cavity so that whenever the urine is filled inside the bladder, when they pass urine, there won't be any block. So previously the block is this much and the passage is only a small thin remote layer. So once we remove this, the whole comes like a funnel, so the patient will have a very good amount of flow, good amount of flow. So the other problem what we come across is urolithias, that is stones inside the bladder. So it is there for long time, even in the 4800 BC also, when they studied the Egyptian mummies, they want to have a bladder stone in their mummified bodies. So it is there for a long time. Most of the times they are not symptomatic, they don't cause any pain. Whenever they are passing through the urine tubes, then they will have significant amount of pain where you cannot sit in one place. So if the stone is there inside the kidney, like this, it won't cause any pain. Whenever the stone is coming into the urine passage, into the tubes, they get blocked like this, the urine cannot come down and it causes dilatation of the entire kidney, which will cause stretch-related pain. So sometimes there can be stones which is formed in the bladder because of the prostate problems. They can have stones because a lot of urine is staying there. Urine contains salts, crystals. All this sediments will form a stone which will be retained in the bladder and cause significant symptoms. So most of these patients who are having a stone inside the passage will come with very acute cruciating pain in the backside. Sometimes it can radiate to the front. And the pain also will be intermittent. It comes and goes, it comes and goes. It won't be a standardized pain. Some people will cause some amount of blood in the urine. And whenever the stone is there reaching to the bladder area, they also present with this frequency and urgency symptoms. And most of the patients, they are present with nausea and vomiting. Because the pain nerves which are supplying the kidney will also supply to the stomach area. So whenever there is a pain inside the kidney, it will cause a reflux into the stomach area, which will cause vomiting and pain. So how we see this patient is whenever we come to the casualty or the OPD, we ask the patient to do a blood investigations and do an ultrasound. Ultrasound will tell us a basic thing, where is the stone, what is the size of the stone. So once we see the size of the stone and everything, sometimes we may prefer to do a CT scan depending upon the size of the stone. Sometimes we just manage the patient with the help of ultrasound. This is an X-ray KVT where you can see the spinal cord. You can see the pelvic bone here. You can see a white structure, you can see, right? So that is nothing but a stone. So kidney will be somewhere here. Urine tube will come like this, and join the bladder here. So this is the way the tubes will be there. So in the tube area, you can see a white color vein structure. This is nothing but a stone. So sometimes the stones can be too large. See, it is like you can see it is there in every part of the kidney. So it is like a stag horn, stag right here. Here which is having a horns. So it has multiple branches and branches. So it is called as a stag horn caliber, where you can see multiple branches here and there. So whenever the patient comes with these symptoms, we immediately start the patient with IV fluids and we give some painkillers. And depending upon the stone size, imagine the patient's stone is only 7 millimeters or less than 7 millimeters, we wait and watch. Sometimes the stones can pass out naturally in the tube itself if the stone size is less than 7 millimeters. If the patient is having a size of more than 7 millimeters, sometimes they may not pass out the stone and it causes a significant amount of pain. Even they wait for 3 or 4 weeks, still the stone gets inside the passage only. So in those patients, we suggest them to undergo a procedure. So what we follow here is we wait up to 7 millimeters, observe for 4 weeks. In this waiting period, we ask the patient if they have any fever or intolerable pain, or if they have increased creatinine, we'll ask the patient to come to hospital immediately. If they don't have any of the symptoms, we'll ask the patient to wait for 4 weeks and we'll give all these pain medications to see. Once they come back to hospital, we'll do a repeat scan again to find out whether the stone is still there or it passed out. If it is still there, then we need to be intervened. So whenever we are doing the stone, or whenever we are dealing the stone, there are a lot of ways now. When I studied my post-graduation, this procedure used to be done regularly. It is called as ESWL, where they used to give a shockwave lithotripsy. The patient has to be lying down on a bed like this, and they focus the stone with the help of an ultrasound machine, and they give a shockwave impulse to that particular stone in a focused way. So whenever this focused ultrasound waves are targeted to the stone, the stone will fragment into bits and pieces, and it will come from the urine tube. So this is called as ESWL. And the recent advancement is flexible ureteroscope, where there is a miniature ureteroscope which can go inside the kidney, see the stone, and get that stone outside the kidney and keep it in a good location, favorable location. And with the help of a laser, it can be fragmented into small bits and pieces. So the advantage with this flexible ureteroscope is with your naked eye you can see and destroy the stone completely. Whereas in the shock wave, we don't know whether the stone is going to break or not. If it is going to break, we don't know how many pieces it is going to be. So powder another, it will come out in the passage. If it is into big pieces, sometimes it cannot come out in the passage. So in shock wave lithotripsy, the powdering of the stone is not in our hands. Whereas in flexible ureteroscope, with your eye, you can see whether you have did a complete job or not. Sometimes if there is any bigger stone, sometimes if we have the bigger stone, then so this is the flexible ureteroscope. You can see the blue stone. You can see the blue one of the laser. You can see the stone here. So you can see the stone getting fragmented. So whenever the stone is getting fragmented, you can see a lot of dust coming. So this is the laser. It always has fragmented stones. You can see like a sand. So whenever you are using the laser, already fragmented bits are flying all around. So it becomes like almost like a sand or dust particles which will come out of the urine passage. So sometimes the stone can be a bigger size. So imagine if the stone is more than 2 centimeters, sometimes from downwards we cannot break the stone. So those type of stones will puncture the kidney through the skin itself, will make a small tunnel-like tube inside the kidney and put a scope directly into there and break the stone and get this fragment directly out through this tunnel, to the skin surface itself. It is called as PCNL, percutaneous nephrotomy, which was done which we do now also for any bigger stone. So imagine a stack-on stone which I showed you. It's a big stone. We cannot do it from downward. So those type of stones we cannot do a flexible ureteroscopy from down. So those type of stones we need to do a PCNL because we can remove a good number of stones or chunk in a shorter amount of time because the tube is much bigger, which will allow to pick out a bigger stones also. So this is how we do. So once we put that thing inside, we can see the stone and we break the stone with the help of a laser, or sometimes we use a pneumatic lithotripsy which will go and poke the stone and break it into pieces. So what we do here is the supine PCNL. So previously they used to do a prone PCNL where the patient has to be sleeping upside down and they used to puncture the kidney. But in Uri we started doing the supine PCNL, which is a recent advancement. Sometimes we do ECIRs, which is endoscopy combined both from downwards. One surgeon will operate and put a flexible uroscopy and start fragmenting the stone. From upwards, one other surgeon will do combined procedure. Whenever the patient is having a bigger stone burden. So in short amount of time, two surgeons will operate from up and down to fragment the good amount of stone. So this is how it is done. So you can see two scopes here. So one surgeon is operating from below and one surgeon is operating from above, and we are fragmenting the stones simultaneously. So even the stones are also miniature now. So the hole for which it is done also is very small. So for any stone patients, for your relatives or anyone, so the most important thing that you need to tell is fluid intake. So any patient with stones, they should take a good amount of water. So normal patients who are not having stone, they need 3 liters. But any stone patient, you advise them to take 3.5 to 4 liters of water regularly. And apart from that, they should avoid salt intake and avoid red meat and high animal protein because it contains uric acid, which is one of the causative factors of the stone. Avoid coffee and chocolates. Apart from that, green leafy vegetables, any green leafy vegetables like broccoli, spinach, all these things have a high oxalate content. Oxalate is also one of a component which can form stones. Carbonated drinks, fizzy drinks, all these things can cause stones. Nuts, especially cashews, can cause stones. Almonds are good, walnut is good, but cashews can have a problem. So this is the right recommendation for us. So you can tell your colleagues or your relatives. So another problem which we come across is phimosis. Any diabetic patients, sometimes they cannot retract the skin down because of the sugar, which will cause fibrosis or tightening of the foreskin. So that foreskin cannot come down and it causes decreased mobility and they are not able to clean the upper surface area, which will cause infection called as granuloposthitis. So which is seen in elderly people who are diabetes. So these patients will come present with difficulty in passing urination, painful erections, bowel micturition, and bowels will be discharged from the penile area. So initial parts we'll ask them to check for the sugars and we'll ask them to do a sugar control, and in extreme circumstances we'll do a circumcision. So circumcision can be done in 2 ways. One is the sleeve, one is the dorsal slit. So anyway, whatever it is, it's a daycare procedure. Patients will come in the morning, they undergo the procedure with the local anesthesia, and they go home in the evening. And after 2 or 3 days, they can have mild discomfort. After that, they'll be absolutely fine. So any diabetic patients who are having a decreased mobility of the foreskin should have this procedure done because it's a permanent procedure. It will help in a long way. The recent thing is stapler circumcision, where the use is divided for stapler, where they insert and just fire the stapler. It will cut the skin and also suture the skin at the same time. So the procedure is going to take only 10 to 15 minutes, whereas the conventional procedure is going to take half an hour. This procedure can be done in 10 to 15 minutes. Same anesthesia, they can be discharged at the same time. So sometimes if the skin is too tight, but somehow the patient has been retracted it back, and they cannot put it back in the same way. It cannot go back in the same way. That time it causes swelling all around, which is a complication of phimosis. So this is like an emergency. Sometimes if the skin is not going back, you need to come back to us immediately. Come back to us. Why? Because the skin is not retracted in a timely fashion. No? This can cause some infection and it can cause some necrosis. So that area will get necrosis, it cause some foul smelling discharge. So any patient who is having a tight foreskin but retracted it forcefully but not able to put it back in a normal way, it's called as parapagnosis. So coming to malignancies, so you all know about prostate malignancy. I think they have done multiple sessions regarding the prostate cancer for the IPCF foundation. So how we do a PSA screening, when to do a PSA screening, and procedure wise how you have this incontinence, how to overcome this, and apart from that, what is radiation, all these things we have discussed in the OP. So IPCF prostate is, I think everybody is well versed of it. So what we come across is the PSA, which is the most important criteria, where we see whether it is below 4 or not, but even in the age of 40 to 50, patients who are having a PSA of 2.5 is also, more than 2.5 is also considered as little high only. So those patients, depending upon the age also, always 4 nanograms per milliliter is not adequate. Patients who are little young people, more than 2.5 is also considered as high PSA, so those should be evaluated. So how we do is by doing a prostate examination and by doing a PSA, and we do a lesion inside the prostate or not. So those lesions are categorized by a scoring system called PIRADS, prostate imaging system, where they give a score from 1 to 5. So depending upon the score, the probability of cancer inside the prostate will be more. So patients who are having a PIRADS score of 3 or 4 or 5, we would have advised to undergo biopsy to find out whether there is any malignancy inside or not. So this data system has been standardized to get the reporting done worldwide. So for people who are there in the US, people who are in Japan, who are in India, there will be a common diagnosis and common scoring system. So to standardize the study, so there is PIRADS scoring. So when you are having a MPMR written, all of you would have done, and they would have written the PIRADS score 1 or 2 or 3 or 4 or 5. So nothing but how the image, and based on the imaging, with the probability of cancer is there or not, that you by the score. And after the biopsy, so we would have recommend you to do a bone scan or a PET CT scan to see whether there is any spread anywhere in the body or not. So if the PET CT is showing that there is no malignancy anywhere, then we will ask the patient to tell them the options of robotic surgery, radiation, what is active surveillance, and so on. So you all would have known this risk stratification: low risk, intermediate risk, and high risk, based on the PSA levels, biopsy scores, and the clinical examination. So patients who are having a localized prostate cancer, that means the cancer is localized to the prostate, not gone anywhere outside the prostate, are considered as localized prostate cancer. Whereas patients having any nodes or the cancer is gone beyond the capsule are considered as locally advanced cancers. So patients who are having a localized cancer, that means early stage cancers, when they come early to our OPD, they have a better chance of having a long-term overall survival, long-term rates of not having any recurrence. So coming to the bladder cancer, unlike prostate, they don't have any symptoms. So imagine a prostate patient who come to our OPD, they'll have some urinary symptoms, evaluate from the board, we got to know that he's having high PSA. But bladder cancers, they won't have any symptoms. They come with history of blood in the urine. This is the starting symptoms. They'll have blood in the urine. We'll ask them whether you're having any pain or not. So classically, bladder cancer patients, they don't have any pain. They don't have any pain while passing urine. They won't have any pain while passing blood in the urine. So that's how classical it is. So patients who are having pain with the blood in the urine, most of the times it can be stone or infection. Patients who are having bladder cancer, they won't have any pain, they'll have blood in the urine. So how we need to screen is regular master checkup, do ultrasound of the abdomen, that time they'll check for the bladder and the prostate. And patients who are smokers, chronic smokers, who are long-term smokers, they should be very careful because the bladder cancer is known to happen in smokers. So if you take prostate cancer, there is no relation with smoking or any other comorbid conditions like diabetes or hypertension or alcohol related to prostate cancer. But there is a direct relationship in the bladder cancer with the smoking. So bladder cancer is again divided into superficial, that means it is starting stage, or it is locally invasive, it's gone little deep into the bladder, or it is gone all the way in the body. So how we get to know is by doing this urinary cytology, where we take the sample of the urine, centrifuge it, collect the sediments, put it in a microscope and see whether there is any cancer cells or not. Or by doing a CT scan, and last one we do a cystoscopy to see how big is the cancer, and we do a dissection. We remove that part of the tissue and send it for analysis to find out how much dirt it is. So the treatment, usually if it is localized, the treatment should be removal of bladder completely, or we can do a bladder preservation like giving chemotherapy and radiation to the bladder. So both are equally effective. Depending upon the situation and locations of the bladder cancer, we will take it forward. So coming to the kidney cancer. So kidney cancer is also recently diagnosed cancers. Why? Because during COVID times, because a lot of people have gone to hospitals, whenever you have a lot of cough and all these related symptoms, they would have advised to do an X-ray. some people they would have advised to do a CT scan chest to find out how much involvement of lung is there. So when they are doing the CT scans of chest, so kidneys are situated just below the lungs, just below the lungs. So when they are doing a chest CT, part of the kidneys are also covered. So tumors which are very small, say 2 centimeters or 1 centimeters or 3 centimeters, which are very small indolent cancers also are found in CT scans, which are done for a different issue, but they got diagnosed with a small size of kidney tumors inside the body. So most of the kidney tumors are indolent, they won't cause any symptoms. Whenever there are big tumors, they will cause blood in the urine. Sometimes they cause with some back pain. Some very rarely they present with a weight loss, all these symptoms. So most of the RCCs which we are diagnosing right now in this decade are very small tumors. Why? Because of the increased awareness, mast cell checkups. So in starting stage itself, we are able to find these tumors. So whenever we find these tumors in the very starting stage, say 2 centimeters or 3 centimeters. So earlier, when 15 years back, 20 years back, whenever these tumors are there, the treatment is removal of the entire kidney. But now the recent studies have shown that removal of the tumors and preserving of this entire kidney is also equally effective. So the size of the tumor matters. So if the size of the tumor is less than 4 centimeters, we can remove only the tumor, preserve the kidney. So all these are evolving concepts. So what I say is all these cancers are preventable if you diagnose them a little earlier. And all the urinary symptoms, tell to your colleagues or tell to your relatives also, whenever they have urinary symptoms, they should not neglect. They need to come to a urologist or doctor to see whether there is any problem or not. So any person who is above 65, they should undergo ultrasound, serum PSA, urine test regularly, periodically, yearly once at least. Okay?